And so it's really a great pleasure that we can invite Connie Davis, who is currently living in Hope, but has devoted her time to improving the partnering skills of healthcare professionals and creating systems that promote person and family-centered care. She's worked both regionally, nationally, and internationally, and as a nurse has devoted her career to the care of elderly and provided clinical care to older adults as a geriatric nurse. She was a clinical director at the team for the McCall Institute for Healthcare, and that's relevant to this province, importantly, because that McCall Institute model of chronic disease management, as well, chronic care model, as well as the patient assessment of chronic illness care, is the one that we use to evaluate the quality of our care and patients' perceptions as one of our tools. So I'm really thrilled, Connie, that you could join us on Friday morning, and look forward to hearing what you have to say. And I'll remind everybody to please put your Q&A in the Q&A box, and I'll curate them at the end, and we'll leave about 15 minutes or so at the end for questions. So over to you, Connie, and thank you again for making the time.
Great, thanks, Adira. It's lovely to join you, and I'm joining you from the traditional unceded territory of the Stalo and the Lakamak people here in Hope. So thank you so much. I'm going to go ahead and share my screen. It's going to be just a tad messy just as I get started. So we'll let you see that. Is that showing for you there? Somebody give me a heads up that we're looking good.
Yes, looking good, but you're not in slide mode yet.
Yep, getting there. Thank you. Okay, excellent. So this is our agenda for the day, for the morning, an hour or less. It's a bit ambitious, but I can talk fast, and I know as busy clinicians, you're used to doing everything just a tad fast. So we're going to talk about what are motivational interviewing and brief action planning. How do they fit in that broader scheme of self-management support? As Adira said, like thinking about the chronic care model that was developed at the McCall Institute while I was there. And also I'll give you just a brief example of how to give information and advice in a way that it's more likely people will take action on it. So that's our agenda. So the first thing I want to do is talk a little bit about some self-management support. So, you know, as we know, we can do everything possible in healthcare, but the outcomes for especially people earlier in kidney disease and more later too, are so dependent on people's behavior. So we can do all the right clinical things, prescribe the all drugs, do all the right treatments, but if people aren't following through in their personal lives, they may not have better outcomes. And just like we step up care in any clinical aspect, you can also step up self-management support. And in healthcare, we know there's finite resources, so we want to give people the amount of support they need. So here's step care for self-management support. So the first step is like the care that everybody deserves. So that's care that fits their culture, that's culturally safe. It's care that speaks to people in ways that they can understand. So that's health literacy, and it invites them to be as involved in their care as they want to be. So that's engagement. So that's for everybody. Then there's a group of people who need a little more help beyond information and being respected and treated well and invited to be involved. They need help sorting things down into actionable steps. So that's where brief action planning comes in. That's also where goal setting happens. That's where we assist people with problem solving, and we monitor the plan. And as you can see from the image, it's a smaller step, which means not everybody needs that. The people who get by with our invitation to care, the first step, those are our favorite patients. They're really easy to take care of. And the next step are people who just need a little bit of help, and brief action planning is something we can do there. And then the next step is really about people who are more ambivalent about change. They feel two ways about it. There's more complications in their lives and in their past that make it hard for them to make a change. That's where motivational interviewing really shines. It's also where we do additional things like care coordination, care management. Sometimes we assign more people to the team in those situations. And then there's this small number of people that really need super specialized care. And for most of us who work in places like renal care, when I was working as a geriatric nurse practitioner, this was care that I could not provide myself. So typically it was when I needed support from a behavioral health colleague or maybe somebody in substance use, and they needed really specialized care that I could not provide myself, but work together with them. So things like dialectical behavioral therapy, people who need more intensive support. And so that's how we step up care. And so just like any set of steps, the bottom steps are really important, or the rest of the steps fall down. So everybody deserves that first level of care, and we step up and down as people need support, so we're using resources appropriately. This also helps you start to think about, well, what kind of skills do people need? And for my role as a nurse practitioner, I needed the first three. I needed to know how to do those things because I was dealing with complex frail elderly in most of my career. And some people on the front line, reception staff, level one is the kind of expertise they need. Many of us need to know how to make action plans with people. That's level two. The other thing that we need to remember is this step care doesn't happen in a vacuum. There's the environment around people that also really is influential. And so how we work together to create a supportive environment is also really important. So that's the family and friend and supporters. That's us on the care team, and that's the environment where they're living and working and playing. So many aspects to think of about step care self-management support. So that's just an overview of where we're going to be going. So I'll be talking about brief action planning and motivational interviewing. And I'm really thinking a lot about individual examples of the way we like to help people. And I'm going to talk to you a little bit more about brief action planning now. And so we're going to talk about that in a way to really highlight a few things about brief action planning. Brief action planning is based on supporting individual change. It's based on motivational interviewing. I'm going to tell you a little bit more about that. It's based on the evidence. There was a group of 4 of us that developed brief action planning. And what we did is we looked through the literature, and we really looked for all of the things that was written about around brief action planning and how you help people make step care change. And so it's very structured, and it's based on 3 core questions. And there are actually some resources on our website. And I'm actually going to pause for just a moment now. And I know that Brenda was going to be sharing a little bit about where you can get the resources. So while you take a look at that, I'm going to go ahead and get a little bit more detailed slides here around brief action planning for you. So hang on just a second while I do that, and let you know that the website, the CCMI website, has lots of different resources that you can use, and that we invite you to go there anytime you want to find out more about any of these things. The CCMI, the nonprofit that I work with, is really there for you. We work with the Ministry of Health in British Columbia and teach these different skills. So I'm going to go ahead and share my screen so we can walk through brief action planning here. There we go. So let's look at these together. Back on here. All right. So brief action planning is really built around 3 questions and some additional steps. So the first question takes place towards the end of a visit. And it's, is there anything you'd like to do for your situation or your health or your current, what's happening in your life in the next week or 2? And when you ask that question, there's typically about 4 ways that people respond to that question. They may have an idea about what they want to do, in which case it's really simple. You proceed through the steps of brief action planning. They may not be sure about what you're meaning, or they may not be sure what they could do to improve their situation, in which case there's a couple of approaches we use that I'm going to tell you about. There's the behavioral menu, or there's ask, tell, ask. They may be ambivalent. They may not be sure. They may be feeling torn. They may be feeling 2 ways about making a change. And then you're going to use additional skills to understand the dilemma and see if you can help them move towards change. That's motivational interviewing. They may say, nope, I'm good, not right now. And if you have a good relationship with that person, you may have an opportunity to find out a little bit more about why. People making behavior change is really determined by 2 things: whether or not the thing is important to them, and whether or not they're confident they can actually make a change. And so depending on what's going on, we use different things to help motivate people towards change. Ask, tell, ask is always helpful. And if people are just really not interested, then we ask permission and see if we can revisit that in the future. So we've asked our question, is there anything you'd like to do for your health in the next week or two? And then we're going to ask, see if they have an idea, we're going to get it really specific. You may have heard about a SMART behavioral plan. The way to get there is really by asking, with permission, some specific questions. So the way I usually do this is say something like, many people find it's really helpful to get specific about their plans. Would that be something that would work for you? And when they say yes, then I start to ask the other questions. What exactly is it you'd like to do? Maybe it's thinking about a dietary change or managing fatigue in a new way, or trying to get a little bit of physical activity. Then it's when. Is this at all your meals? It's some meals, on weekdays, on weekends? Is it in the evening, in the morning? Sometimes where is the right question. If you're going to take a walk, where are you going to do that? Even more specific, how often, how long, how much? It might be about serving sizes. It might be about how many. It might be how many minutes. And then a start date. It's helpful to be specific and have a start date. If the person doesn't have any ideas, again, we ask permission to share ideas. And then the best approach is to share 2 or 3 ideas. And the last idea, we try to elicit their own. It's unlikely that I'm going to figure out the perfect example to their solution to their problem. So we want to do the point of problem solving is in using a behavioral menu is to help people come up with their own ideas. So the way this sounds in practice, and I'm going to give you a real example from a gentleman I worked with who lived in a single room occupancy housing, and he was having a hard time remembering to take a twice-a-day medication. And so this is kind of how the conversation went. I'm just going to call him Mr. Smith. Mr. Smith, would it be okay if I shared some ideas with you from other people I've worked with who've been having problems taking their medication regularly? He said yes. And then I said, well, some people link it to something that they already do in their life, so something in their routine. Some people decide to use a pill box like a MediSet, or some people decide to set a timer so they'll remember to take their medications. Would one of those ideas work for you, or do you have an idea of your own? And Mr. Smith looked at me and he said, well, I do keep a pretty strict routine. And he said, well, what do I do twice a day? Well, every night I brush my teeth so I could put my pill bottle next to my toothbrush. And every morning I put on my shoes. So after I brush my teeth and take my pill, I'll move my pill bottle to my shoes. And then when I see my pill bottle in my shoes in the morning, I'll take my pills and then I'll put it back by the toothbrush. And so that's the idea he came up with. Now, I guarantee you, in a million years, I would have never come up with that idea. So that's the whole point, is to help the person solve their own idea. You may have noticed I did some other things really specifically there. The ideas came from other people like him, not from me as the expert. And I was really trying to get him to solve the problem, supporting him to solve the problem. So that's using a behavioral menu. The next thing you do in brief action planning is have the person say the plan back to you. It turns out the strength of the language they use is really indicative of whether or not they'll complete their plan. So the way this sounds is, we've been talking about the plan of what you're going to do in the next week or two. Would you mind saying it back to me just so we're on the same page? And then they say the plan back. When people say things like, I am going to, you know that there's a good chance they'll do it, all right? The next thing we do is ask them how confident or sure they are that they're going to carry out their plan. So that's on a scale from 0 to 10, or you can just use words, sure, not very sure. So it kind of sounds like this. How sure do you feel you'll be able to carry out that plan to take your medication twice a day? On a scale of 0 is not sure at all, and 10 is you're totally sure. What number would you give it? Okay. And based on Bandura's theory of self-efficacy, we know that when people's confidence level is pretty high, they're more likely to carry out their plan. And so if their confidence is less than 7, we say something like a 5 is higher than a 0, and that's good. But we do know that when people have a confidence level of 7 or more, they're more likely to complete their plan. Do you have any ideas about how it might raise your confidence? Again, we're trying to ask people to solve their own issues to help them find the things that are going to fit for them. If they do, that's great. We check back in, see if the plan's going to be more higher confidence level. If not, we use that behavioral menu again. Would you like to hear some ideas from other people I've worked with that have had low confidence level? And that's pretty easy to problem solve because typically it's around issues like not setting up a reminder or biting off more than they can chew, taking on too big of a plan. So we can help people problem solve. The third question in brief action planning is asking people if they'd like to set up a check on their plan. And of course, this is for accountability. It doesn't have to be with you. A lot of people use their devices now to set up checks on their plans, or they might have a family member or a friend that they would like to do that with. If they're checking on the plan with you, it's really simple. You ask them, how did it go with the plan? You don't even have to be the one who set the plan. Anybody can follow up on it. If they completed it, recognize their success, ask them what they want to do next. It might lead to another action plan. If they partially completed, and this is in my experience the most common thing that happens because we have good intentions and then our life kind of gets in the way, recognize the partial completion, because most of us tell ourselves that if we didn't do it all, that we failed. And so we need to kind of correct that and put people back in a confident place. Sometimes people just really don't get a chance to try their plan. And we want to reassure people that this is common. And then again, ask them what they'd like to do next. They might want to take a breather. They might readjust their plan. So this is what it looks like all together. And you have a handout that's going to help you with that. Okay. So again, I'm going to stop my sharing for just a brief minute and get back to the other slide set. I had forgotten I wouldn't be able to give you handouts in the way that I wanted. Okay, so let's go ahead and get back to MI and thinking about MI. All right. I hope you're asking questions and thinking about what you would like to talk about when I'm done talking to you very quickly. Okay. So I'm going to give you a definition now. This is the definition of motivational interviewing. So think back to that stepped care approach just a little bit, and maybe I'll show you that just a bit, again, just so a reminder of where we're at. So the green, that second step, that was brief action planning. So brief action planning is really for a specific group of people that we work with, group of patients. It's the people who know what to do. They're having trouble getting started. So there's not a lot of ambivalence about it. They know what they're supposed to do. They're just kind of stuck, okay? It's really designed to build people's confidence. I said that importance and confidence are two things that make up readiness to change. Brief action planning is really designed to build confidence, okay? So if people are feeling ambivalent, if they're feeling torn, they're really seeing a lot of barriers, it's really a struggle for them, that's when we go to step 3. That's where a lot of what motivational interviewing comes to bear. So motivational interviewing, a public definition, is that it's a collaborative conversation style to strengthen a person's own motivation and commitment to change. Okay, and so the thing about motivational interviewing is that it's really drawing forth that own motivation and commitment to change. It may be deeply hidden, and it's one of our jobs is to try to find that out and pull it forward. So this is what I mean when I'm talking about ambivalence. And if you think about ways you've heard patients talk to you, there's language that people use that either moves them towards change or moves them away from change. So when we think about that, you might want to think about somebody, let's think about somebody who's really contemplating a different way to manage stress in their life, okay? And so they might be saying something to you like, I've really got to get this stress under control. I know it's affecting my sleep. I'm just really not feeling rested. But there's so much going on right now. I mean, I'm so worried about my family and friends and the pandemic. And I just, it's always on my mind, what's going to be happening next for me. But, I had a friend tell me a little bit recently about how relaxing they were finding it just to spend some additional time outside. And so as you hear that person talk, what you see is they're kind of moving forwards and towards change, and then they're moving back, and it just goes back and forth. So that's what we mean by ambivalence. Ambivalence is normal. All of us feel it all of the time when we're faced with change. And sometimes when we hear it in patients we work with, all of a sudden we think it's pathological, but it's really quite normal to feel this about change. And it might be so normal that that conversation I was just having out loud might be something you're thinking about yourself, or you might be thinking about some other aspect of your life and change in your own life. And so that motivational interviewing is really being with somebody while they're contemplating change and seeing if we can tip the balance towards the change. I want to tell you a little bit about the evidence for motivational interviewing. At this point in time, there are well over 1,000 randomized controlled trials of motivational interviewing. And many of them were done in substance use, which is where motivational interviewing came out of alcohol treatment. Many of the newer studies are actually in healthcare. And the studies are really interesting because there are studies of when motivational interviewing seemed to work, and thankfully also some published studies of when motivational interviewing doesn't seem to work. So we can learn a lot about both of these things. And the developers of motivational interviewing, there's a couple of psychologists, Dr. Bill Miller and Dr. Stephen Rolnick, have really been teasing apart, and more studies have been done lately that really tease apart what is it about motivational interviewing that does seem to help support people making changes. The two things, the first one is called the spirit of motivational interviewing. So that's the attitude around change, the philosophy, the way you actually approach or be with people while they're contemplating change. Dr. Miller really believes that about 80% of the effectiveness of the motivational interviewing approach is around this spirit of motivational interviewing. So we're going to spend some time there. The second thing that seems to be effective with MI is paying attention to the language of change. So that walking back and forth and those words I was saying, we hear that all the time. And what we don't always know is how to respond to it in a way that can strategically guide the person towards change. So spirit and attention to language of change. Now let's think a little bit about when MI doesn't work. And so there's been some studies, including one that was developed by Dr. Miller himself, where MI didn't work. And when really looking deeper at that, there seem to be two things that are come up when you look at those studies. The first one is lack of fidelity. And what that means is the researchers actually didn't measure whether or not the clinicians in the study were actually using MI. Now, MI has been around for a long time now. We actually have tools where you can listen to conversations and hear whether or not people are using these principles and these practices of MI, that spirit and that attention to the language of change. Our team at CCMI has been trained in some of these coding tools. It's really fascinating to listen to people's conversations and hear the opportunities to alter the response to support change. So lack of fidelity. So high quality research of things like motivational interviewing need to include fidelity measures. So those coding tools that we use, so you do them after you train your clinicians in the approach, and then you do it during the study and a random sample, and then you do it at the end of the study and see how people are retaining their skills. There's also some more known about skill retention in MI too, but I won't go into that today unless you're interested. The other thing that doesn't seem to work is to overly script motivational interviewing. And when you're talking to people about change, when any of us are talking to people about change, we really have to be listening intently, paying attention to where the person's at and those things about importance and confidence, and listening to what they're talking about and responding to them in that moment. The scripted study was actually done by Dr. Miller. People were criticizing him, saying motivational interviewing was too hard to learn, and couldn't he just script it? So they actually did a study where they scripted a treatment plan for people in alcohol treatment, and it didn't work very well because there's, if you, for example, they found that if they asked people about barriers who were already ready for alcohol treatment, if they asked them about why they might not want to quit drinking, it turns out it made them more ambivalent. So you really have to be listening to people and doing things in the moment. Okay, so that's what we know about the research in MI. So what is MI really, really about? So that spirit that's so important that Dr. Miller thinks is 80% of the effectiveness, here's the spirit of MI. In motivational interviewing, like in all of medicine, we like acronyms. The acronym for the spirit of MI is CAPE, and it stands for compassion, acceptance, partnership, and evocation. So in this definition, compassion is a simple way of thinking about it is empathy with action. Okay, so really understanding the situation that the people we're working with are in, but taking action on that. So compassion, feeling what's moved by another, feeling what's important to another person and moved to help. Acceptance, there's many factors in acceptance, but the one that it's really comes to the fore is acceptance of people's autonomy, their right to change or not to change. We may not agree with the change, with their decision, but if they've not been declared incompetent, they have a right to make a choice we don't understand or don't agree with. So accepting people's autonomy, very powerful in supporting change. Partnership is the third one. And so that's about collaboration. So that's like working with someone else as an equal. You all bring amazing expertise to the interactions you have with the patients and the clients, the people that you serve, the families that you serve. They also have amazing expertise about themselves, their lives, what's worked for them in the past, what their situation is like. So that part of the aspect of Spirit of MI is bringing both of our expertise to the conversation and acknowledging their expertise. The last part of the spirit is the spirit of evocation. I like to think about that as encouraging people to explore. So that's a gentle curiosity about how people came to be where they're at. And that again can encourage them to explore their own lives and consider change in another way. So that's the spirit of MI. And that acronym is really kind of powerful if you think about what CAPES can mean. Now, this isn't quite a cape, but it's a garment that people wear to acknowledge an achievement. And so that spirit of MI, a part of that expertise that we want to acknowledge is recognizing people's strengths, affirming their strengths, acknowledging what they've accomplished. Here's another image of a cape. And this is a cape we're very familiar with in the Lower Mainland. This is a cape that's purpose is protection. And change can be challenging. And so when we're with somebody who's contemplating change, we want to protect that space and hold that time and that place for them so that they can really think about change. Here again is another kind of a person who wears a cape. This is not quite Gandalf, but if you're familiar with the Lord of the Rings or any fable that involves a wizard, there's a power and a strength and a magic around working with people around change that we want to really bring to those conversations. And of course, there is this use of a cape. So this is putting a cape on a child, and we know that gives them superpowers, and that's really what we're doing in that MI conversation. We're trying to draw forth that person's own strength, their own abilities, their own intentions for change. So that's the spirit of MI. Again, 80% of where the experts believe the effectiveness comes from, which is freeing in some ways, because if we're thinking about this attitude or this philosophy and guide our language with this approach, we can really help people towards change. And so there are ways you can directly express the spirit of MI in an interaction. So when we talked about compassion, that's taking action. It could be simple things like attending to somebody's comfort, during dialysis or during an interview, making sure there's privacy, that the room is warm, that for the older adults I work with, that there's good light on my face, that they can see my face so they can read lips. So anything we do that takes action and helps somebody feel comfortable and safe is compassion. And then there's acceptance. Acceptance is fairly straightforward to put into words. Whenever you say things like, it's up to you, or there's several choices about where to go from here, or when you ask permission, would it be okay if we talked about this? Any of those things are showing acceptance. Partnership, again, easy to put right into words. Saying things like, we can work on this together, or what you know about yourself is going to be really important to whatever next steps are you want to take, or I'm here to be beside you while you go through these things. Okay, so partnership, important stuff. And then that evocation is, again, that attitude of respectful curiosity. Tell me more about that. How does that work in your life? All of those things are that spirit of MI. Now, if you like analogies, here's another analogy to think about the spirit of MI. And I often recall this when I was working as a clinician. I'm retired from clinical practice now, but it's like the difference between dancing with your patients or wrestling with them. And sometimes, when you're in a conversation, I know I would sometimes really care intensely about what was happening with somebody, be very concerned about their future or their safety. And it would start to feel like a wrestling match. I would start to feel that tension in my own body and just kind of notice I was getting a little more pushy with my words. And when we push with our words, people respond in one of two ways. They either push back and we call that resistance, or they say that they're going to do things, or they kind of give up and kind of look away and they turn away from us. So whenever I started to feel that wrestling, it was a reminder to me that I needed to change my strategies and get back to dancing. And this kind of dancing, like seen in that picture there, is the kind of dancing where one person's guiding. In this case, it looks like it's probably the father of this woman. Probably this is a quinceañera party, if you're familiar with the culture. And so that man, in this case, would be guiding the dance. And that's what an MI conversation is like. It's not a free-for-all. The person who's thinking about MI and being with somebody with this spirit of MI is guiding the conversation so that something really beautiful happens. So dancing versus wrestling. So a little clue, when you start wrestling, you know you're a little bit off track. All right. So where we've been is thinking a bit about this step care level of care. We've been talking about brief action planning for people who just need help breaking things down. Now we're talking about people who are more ambivalent. Something we do all the time in care is give information or advice. And there are some ways that we can give information or advice that it's more likely for people to take action on them. And if you asked anybody who knows motivational interviewing around the world, and I'm lucky enough to be part of the organization called the Motivational Interviewing Network of Trainers. It's an international organization of people who really want to promote motivational interviewing. It was founded by Drs. Miller and Rolnick. They would say that learning how to give information and advice in this way is one of the most important things anybody could do. And it's pretty straightforward. And some of this you may already be doing, and some of it may have some additional very important tips or hints for you as you go forward. And the approach is called ask, tell, and ask. So I'm going to just show you just a little bit more with this slide, what this sounds like. So ask, and this also gets called elicit, provide, elicit, by the way, just kind of really big words when ask, tell, ask work. Ask is how you open the conversation about giving information or advice. And there's two ways you can do it. You can ask permission to give your information or advice, and you might recognize that that's about autonomy. That's about the spirit of MI. Or you can ask people what they already know, which is incredibly useful and very efficient. Then you don't have to give your spiel if you don't need to. They can tell you what you know, can save you time. And again, that's the spirit of MI, that's evocation, that's exploring, right? I'm asking a question to evoke from them what they know, or I can ask them what they want to know, all right? So the way this sounds is, it might sound like, well, when I was working as a nurse practitioner, it sounded like, would it be okay if we talked about some things that can really help you stay independent in your own home? Rarely would there be a frail senior who wouldn't want to talk about that. So then I have an entree to just keep going. You might be saying, they came to see me, they know what I do, why do I need to ask permission? It's true they did come to see you or they agreed to the appointment, but they might not be agreeing to exactly what it is you want to talk about. And so that is very respectful to ask about going in that direction. If they say no, isn't that a really important thing to understand? If you're in the renal clinic and you want to talk to them about their kidney function and they don't really want to hear about it right now, there's something really important going on with that person that's worth knowing. The other thing that asking permission does, especially if you're like a physician, my physician colleagues tell me this all the time, if they ask permission to say something, it really gets the patient's attention. Whoa, this is so important, they're asking me if we can talk about it. So it can serve that function too. So asking first, there is kind of permission has a kind of a shelf life. So if somebody said, hey, can you tell me more about, or, I'm here to find out more about this, that can hold for a little while. But if you're starting to maybe change the topic or it goes on, you might want to circle back to this question or ask them what they already know. Or even if they say, I want to know more about, how high blood pressure plays into this whole kidney thing, I don't understand. Well, you can again say, well, what do you already know about that? Well, I know my brother-in-law had this before and I didn't quite get it, but he said that he should have been paying more attention to his blood pressure. So that gives you a starting point for the conversation. So even if you have permission, asking what they already know and what they want to know can be very efficient. Then you tell your information. I'll give you a few more tips in a bit, but in general, it's a limited amount of information or chunking it and using plain language. And then the thing that is left off the most is the second ask. Again, this is really important to kind of keep that spirit of MI there. The first option is to say, what do you think about what I just told you? What does that mean for you? Okay. And elicit back what their thoughts are. This is going to give you a lot of information you can use for supporting change in the future. Or if it's something really important, you're going to use the approach called teach back, which you may have heard from. That's from health literacy, really important to check for understanding. Okay. So before I go into that in more detail, you see from in the chat box that Brenda's been giving you links to some handouts. There's many really helpful handouts on the website, but there's one for Ask, Tell, Ask. It actually helps you figure out what words might sound natural for you. So when you see that handout, it'll give you some options of what you might want to say to ask for permission or what they know or want to know. When you get to, oops, sorry, I went one slide too fast. When you get to the tell part, there's some really helpful tips. This is from health literacy. Health literacy is one of those foundational concepts in that step care self-management support. This is about making sure this information is focused on the present, what the person really wants to know right now. Again, that's helpful when we're in time-pressured situations. We want to provide the information in a neutral way. And so instead of saying things like, you should, we say things like, sometimes people in a situation like yours do this, okay? So again, I'm trying to get the expertise more even. Or if you're like looking at lab results and you could say, let's look at these lab results together. You can invite them into the conversation. Focus on one or two key messages that they want to know. If you do have to give a lot of information, the approach that's recommended is called chunk and check. So you give a chunk of information, you check to see what they're thinking or what their understanding is. You give another chunk, you check again. So chunk and check. Use living word language. So language in their living room, not mine, not yours. Probably you speak a little bit differently in your living room, what an average person might say, the members of the public. Use pictures and handouts when they're helpful and mark them up. Draw arrows, circle things, write their own numbers, their lab results on them, make them personal. Emphasize choice and options, avoid words like can't, must, or have to. Talk about choices and talk about choices that sometimes lead one way or lead another, okay? That's informed decision-making and a whole other thing I'd love to talk with you about sometime. Again, this last part of Ask, Tell, Ask is the thing that might get left off most frequently, to ask these questions. Let's just move on. So ask them what they thought, or teach back. If you've never learned teach back before, this is the most evidence-based thing from health literacy. And it's a test of the person giving the information, not a test of the person's receiving it. It's the best way to help someone understand information. So the way teach back works is it has to be phrased very, very carefully. My favorite way to do it is to say something like, we've just talked about quite a few different things. When you go home, your daughter's going to ask you what happened in the appointment today. What are you going to tell her? So then I know not only what they remembered, I also know what they thought was important, and I know how accurate it is that the information, how well I conveyed the information to them, what their understanding is. Another great way to do teach back is to say, we just talked about how you're going to adjust your medications after this appointment. Would you mind saying it back to me so I know I was clear? That last part is the crucial part. You have to be really clear that it's a test of yourself, not of the person you're giving the information to. Okay. And if you tack on so that you understood, that blows it totally. You may have had the experience where you ask people, do you understand? And they nod their heads. It's a rare person who's going to say no in that situation. So phrasing the question, would you mind saying back to me what you're going to do next, or what we just talked about, so I know I was able to communicate clearly. Okay. It's about what I did. Teach back has been shown to decrease no-shows of appointments. If instead of us telling them the appointment time, having them say it back, we can help that way. It's also really helpful in helping people come into adherence with their medication, because then we know that they've got the instructions before they leave, and you can actually document in your note, patient was able to teach back information, and then any clinician following you will know that at that point in time, the person did understand what the directions were, okay? So highly recommend teach back, lots more information about that. Often in healthcare, we have a special obligation to give people information. And in the handout that I've provided, there's ways you can say that. Things that I used to say to clients that I was working with as the nurse practitioner, I'm very concerned about some things I see in this environment. I've not seen that there's any fresh food in the home. It doesn't look like you've been shopping for a while. And I know you told me that your finances are really giving you trouble right now. Would it be okay if we talked a little bit more about some ways that you might be able to get some help about getting adequate nutrition? So you never give up, even when you're asking permission, you never give up those professional obligations of things you have to do. If people ask you to tell them what to do, there's some other ways that you can still emphasize choice. And it's really all about that behavioral menu. They ask you what to do, you say, well, I can't tell you what to do, but I can tell you what some other people have done in a similar situation. So then again, normalizing it. Okay, I know we want to have some time for questions and answers, and I just want to let you know that there's lots of ways to learn more about brief action planning and motivational interviewing. Again, the nonprofit I work with, we offer these things. There's lots of resources, videos, things you can watch on the website if you're interested. There's courses and workshops and things that you can take. There's lots of books and things written about motivational interviewing. Our website's the first one there. There's an entire press series about MI. There's actually one of our colleagues in Ontario has done some quality improvement and some research about brief action planning and MI in renal care, where she's working. There's also been a study of MI in kidney donation. So lots of things to think about. And so I just want to thank you for listening to me very quickly and tolerating me going back and forth between those two slide sets there. And I'm going to stop sharing and we'll see what questions you have.
That's great. Thank you, Connie, and thanks for putting that together. There was a question as to whether or not you would be comfortable sharing a PDF of your slide deck, because although we record it, if you're comfortable with that as well, is that possible?
What I'd like to do, rather, is actually share the tip sheets with you of everything I covered, because the slides are not going to be helpful, but the tip sheets are going to be the best. So I will make sure you all have, and you can download them from the website, the Spirit of MI handout, which has those things you can say. The Ask, Tell, Ask handout has all that information in there. So all of that will be in the PDFs, and I'll send those to Brenda.
Great. So I encourage you to put some questions in the Q&A, and I'll
live question.
Oh, go ahead, Brenda.
Oh, actually, never mind. They took they unraised their hand.
That? Sorry?
They put their hand down. Never mind.
People want to ask a question, you put your hand up. Oh, there you go. John Walcott. Put your hand up. Unmute. Oops.
Hi, John, if you come off mute. Lower left corner.
Yeah. Up your Brenda, can you unmute him? By any chance? Well, maybe we'll move to Jennifer. Oh, there you go.
Oh, wait, there.
Go ahead.
Okay. The main thing is this lecture more for the patient or the professional?
So yeah, well, that actually, John, I think you bring up a lot of questions there that are really interesting to think about. So brief action planning is something we hope that everybody learns how to do when you want to make a behavior change. So lots of folks learn how to do it. And as a professional, when I'm making brief action plans with people, I hope it's a skill they pick up and carry on in their lives when it's useful to them. We teach peers these things to teach each other how to do all the time. Same with motivational interviewing. Peers can learn these skills. Anybody can learn these skills to help somebody to make change.
Yeah, great question. I guess the other thing I was going to, maybe I just saw there was another question with a hand up.
I saw the one about resources, and yes, we can make sure you know where those resources are.
There was another hand up. Okay, I was going to ask you in terms, so our biggest, well, there are many challenges, obviously, but language differences, motivational interviewing, either with an interpreter or in broken English.
Yes.
There are specific challenges, and I think many of us would be quite interested in your thoughts around how best to manage that.
Yeah. So the
There's no
good news.
internet about how difficult it is.
Yeah. So yeah, familiar experience for all of us. So the good news is if you yourself are bilingual, the motivational interviewing book has been translated into over 60 languages. So you can access it in all kinds of different languages. For brief action planning, we have that in many, about 8 different languages on our website. We do have an Urdu version that's not on our website, but if somebody needs that, I could send that to you. So this has been done in all kinds of different languages. If another question people often have is, does this work across cultures? It's actually been found to be more helpful in cultures that aren't the majority culture in a country. And the belief is because it's such a respectful approach. So we do know that. As you know, when you're working with an interpreter, there's a few things you can do to help, and one of them is to have that pre-session little time together to talk about what's going to happen in the visit, if at all possible. And if you're working with a professional interpreter, let them kind of know the shape of the conversation and remind them that you want them to translate things as exactly as possible, or let you know if there's some cultural things that they need to take into account about how people talk about things or talk about change. It's just going to take a little more time, and you might want to go towards the simpler sentences and not be using things like metaphors. Metaphors do not translate well, but change is change across cultures. The thing about change that can be very different across cultures is how people think about decision making. And this is stuff, who should be involved in the decision and how you want to engage others in the decision making as well. So yeah, all of those things are really important.
Great. So there's some great questions. So what do you say to people who say, I don't have time to do these in-depth conversations?
Yeah. So it may sound like it takes a lot of time. And what Bill Miller says is, if you only have a little bit of time with somebody, you don't have time not to do this. And so I guess if you think about it, if I have only this short time to interact with this person, I better do the most I can to help support them towards change. So I think that's kind of the thinking there. And I know I found that true to be in my work as well. Sometimes these approaches are often used in brief interventions, like 10 minutes or less in an ER. Right. And so they can be effective in brief interventions. And a brief intervention basically is ask, tell, ask. Right. And so having that supportive language can really make a difference. And it's cumulative. So you take that approach in your 5-10 minutes, the next person takes that approach, we all get to build together. Yeah.
And I guess I would just add, if you don't have time to do it, then you do it wrong. You don't have time to do it. You have to make the time to do it right. Like it doesn't help not to do it.
Yeah.
There's some other general questions about how long does it take for a clinician to establish these basic skills? And I guess that's about self, right?
Yeah. Well, I can tell you some things we do know, just starting with brief action planning. So when we teach people brief action planning, and depending on if it's just one-on-one, you can learn it pretty quickly. You can actually learn brief action planning by, reading the materials and watching some videos on the website. We do a skills check, and you'll find on the website, there's even a skills check handout. There are some health authorities that actually build brief action planning into their orientation and have people, just like you would get checked off on, how you're going to use a piece of equipment, you get checked off on whether or not you can make an action plan with people. It's fairly easy to learn. We actually do a certification, like if you're doing research, so you can know people actually can demonstrate the skill. And so it's pretty easy to learn, I would say an hour or two. Some people pick it up even faster because it's pretty natural for them. We have practice sessions. You can go on our website. There's drop-in practice. Anybody can come, both for MI and for brief action planning. So that doesn't take very long. For some people, motivational interviewing is very natural because they already get the spirit. And some people have more habits they might need to unlearn, so it can take longer. So I can't really give it a number. When we do workshop-based things for foundations of MI, it tends to take about 16 hours, which could be spread out over however much time you want to do practice and feedback. There's online courses. You can do a little bit here and try stuff, and do a little bit and try stuff, right? So it's highly variable, highly variable.
Great. Yeah, and I think, there's some questions around people interested in looking at formal training sessions. You've given us some ideas about how, tools and stuff that people could use and put into practice. And perhaps we will certainly circle back. There's a very pertinent question that I think we come up a lot with. And you maybe alluded to it in one of your comments earlier, but how do you talk to people who are in denial with respect to kidney disease, don't want to have treatment or talk about dialysis options, and yet tell you that they want to live. And I think you alluded to it before. There's something else going on, but like that is a
Yeah.
very frustrating thing for many of us. So
Yeah.
your
So
thought.
yeah, and so that's actually what there's an approach that's used in that situation. It's called developing discrepancy, and there's actually a little like a little miniature unit. So if you ever want to look up developing discrepancy, that's what it's done. And so the kind of things you do to develop discrepancy is explore people's values. You know, like people will say, well, I'd really like to be around for my grandkids or something like that. And say, you know, your family's really important to you. And then you can also just express your puzzlement. It's like, you know, there's two things I'm hearing and I'm really having a hard time getting them fit. Maybe you could explain it to me. You know, you really want this and I also hear this and I don't see how they fit. Can you help me understand this? And have them explain it to you. Because what happens is people's words talk them into change, not what we say. And so a part of it is helping them talk it through so that they can come around to that conclusion in a way that's going to work for them. And I think I see also in your face, Adira, I mean, there's fear underneath that. I mean, there's a real fear underneath that. And so sometimes people need to have more time to kind of think through what does this mean? So, which is also why I'd love to talk to you more about informed decision-making, how to support that.
Yeah, and actually it's a fantastic segue because, you know, number one, this is, you know, Kidney Month and we're celebrating this. We also have a strategy provincially in terms of improving our goal setting in the context of self-management for our patients. And we've been doing a lot of that. And I think, you know, forcing people to make a decision because you want them to make a decision is exactly what you're saying, is like, they're not ready. So that's okay.
Yeah. Well, when we push, they push back or they kind of say they're going to do stuff and don't, and we get frustrated. I mean, yeah. So the pushing is, it's like that, you know, you keep doing it over and over again, it still doesn't work, right? Like,
yeah. And I think it is about us, you know, being a little bit more knowledgeable about self and what it is, why we want them to make a decision today.
Yeah.
It's
Get back to dancing.
what? Because I want it done now, so I can tick it off my box, and that sometimes doesn't
Exactly.
work. With especially, I
Exactly.
think we underestimate how complex some of these decisions are. This isn't like, you know, take a pill. Like going on dialysis isn't like take this pill because that'll make it better. It's a big, complicated
It is a big
decision.
Yes.
So, you know, I think we perhaps underestimate that, for
Mhm.
example, even things that we think sound really good, like getting a transplant, you have no idea what that evokes in people, other
Yes.
things.
Yes, indeed.
So I guess with that, I'm just looking quickly to see if there's any additional questions. You know, mostly a lot of positive feedback. And I will sort of reiterate something that you said. I think it really is important for us to do a check-in as to what people heard us say, because I had a very interesting interaction this week on the ward with a very interesting person who hasn't interacted with the healthcare system for 45 years. And I would say it one way and I would check and figure out, and we would have a conversation. Someone else would come in and I think said the same thing, but with different words. And what he heard other people say was different than what he heard me say. And then I had to do a lot of redoing. And that's not that they said it wrong or right. They just, he heard it differently. And I realized getting more and more afraid because he was hearing things that made him scared. And it wasn't anyone's intention to scare him. But I think we have to also be conscious that we all say things different ways. And so I like the notion of check in, what did they hear you say? Because what you said and what they heard might not be the same.
Well, to close that loop and then to hold, you know, even back to it, if you're the next person coming in, said, what's your understanding of? And they can tell you in their words, and then you know where to start, right? Yeah. We sometimes we could be more efficient.
What do you know now?
Yes.
What did you hear other people tell you? Yeah, I think that's a really great one for us to remember.
Yeah.
Listen, it is bottom of the hour, and I want to thank you again for making time. And I think you've certainly motivated a lot of people to learn more, which is even really, we will certainly loop back, and I think we'll certainly socialize all the toolkits, obviously, and this will come out with this, with all the different tips that you've given us, but also perhaps some small group sessions that I think I'm hearing people wanting to have or see how you could help facilitate those. So
that'd be great. That would be great.
Thank you again.
Thanks, everybody. Thanks for the opportunity and take care.
Thanks. Bye-bye.
Bye-bye.